A very good evening to you, ladies and gentlemen. Welcome to yet another online lecture that is organized by Dentistry, which is the academic branch of Government Dental Surgeons Association. As you all are aware, we've been conducting a number of lectures under the lecture series of life cycle approach in dentistry. We started from the care of pregnant mothers, and now we are in the final lecture. On the lecture series, we are dealing with the management of children. So in the last lecture, we were talking about the periodontic guidelines, whereas today we will be dealing about managing emergencies in the dental setup. So our resource person is Professor Pathum Dissanayake. He is a professor attached to the Department of Pediatrics in Faculty of Medicine, University of Peradeniya. I've had the privilege of attending a number of sessions conducted by him in the medical setup as well as in dental setup, and he has been one of the most interesting lecturers that we've come across. So without further ado, I'd like to thank Professor Pathum Dissanayake for accepting our invitation, and I'd like to ask him to conduct this lecture. It's over to you, sir.
So thank you, Kemia. I think everyone can hear me. So first of all, thank you very much for inviting me for this online lecture series. And as you said, I will be doing a lecture on pediatric emergencies. I will share the screen now. If you can see the screen, give me 1 minute. Okay. Kemia, can you see the screen?
Yes, sir, we can see. We can see the...
Okay.
Yes.
Okay. So we'll start the lecture. So my topic today is pediatric emergencies, which can happen anywhere, not only in the dental practice. So these are very common emergencies where we come across, and we hope that we will not come across, but unfortunately they can happen anywhere for any practitioner. So I will be giving my lecture on the following topics, and at the end I am happy to answer any questions you have. So before we go to the subject, we will talk about the basic life support. That means the common approach to emergencies in any situation, and then we'll take several topics like choking, child with status epilepticus, anaphylaxis, status asthmaticus, and cardiac arrest. These are the common emergencies which can happen in your day-to-day practice. So it's important that we know the current and the latest guidelines on how to manage a child. So regarding basic life support, there are different guidelines. So I will be talking to you on the advanced pediatric life support by the Australian faculty, Australian Pediatric Life Support Group. That's the most commonly accepted one. So we will go according to that guideline. So basic life support, according to the Australian guideline is called the, it's called the DRS approach. It's called the DRS approach. And when you find any child who is in an emergency situation, we should go by this approach. And DRS stands for danger, responsive, and send for help. So whenever you see a child in any emergency, the first thing we need to do is we have to look for dangers which can further harm the child or further harm you. For example, if there's a child who is unconscious and there's a lot of smoke around, that can be a danger to both the child and you. So you need to drag the child away from the smoke. Or if we are dealing with a child who has been accidentally electrocuted, we need to make sure that we don't get electrocuted and the child doesn't get electrocuted further. Once you are away from danger, we need to check whether the child is responding. So the best thing is shake. Now in this photograph, we can see someone is trying to shake the head of the child. That is not recommended because we don't know that this child might be having some problem with the neck, a cervical injury. So best thing is to shake from the shoulder and see whether he is responding. And or you can shake his limbs and see whether he is responding. If he's not responding, that means it's an emergency. We need to go for the basic life support. But before you start life support, try to send for help. Because by the time you are through with the basic life support, the help would have arrived, right? So we are trying to save time. So look for dangers, see whether the child is responding, and then send for help. Then only you go for the life support approach. So what do we do in basic life support? The first thing to do is open the airway. So DRS and then A. Opening airway, it depends whether the child is an infant or a child. Okay, a child is anyone who is above 1 year. Infant is a pediatric patient who is below 1 year. Now, if it's an infant, we keep the head in the neutral position. That means the head is in line with the body, neutral. If it's a child, we keep the head in the sniffing position. That means the head is slightly tilted. The chin is slightly tilted above. So this is called the sniffing position. And what we do here is we do a procedure called chin lift and head tilt. So we lift the chin so that we will lift the tongue away from the oropharynx. And this maneuver will help the child breathe properly and the airway will be clear. Okay. So you are tilting the head to the back and lifting the chin. Chin lift and head tilt. In a bigger child, you do the same, but while the child is already in the sniffing position. So these are the two differences. In the infant, neutral. In the child, sniffing position. So once you have done the chin lift and head tilt, you go to the third procedure, jaw thrust. Okay, so there are 3 procedures to keep the airway open: chin lift, head tilt, and jaw thrust. And what we are doing by jaw thrust is we keep our fingers on the angle of the mandible and push the lower jaw upwards. By doing that, you are again pushing the tongue upward and preventing the tongue blocking the upper airway. Okay, so these are very simple maneuvers but life-saving. Okay, so look for danger, responsiveness. If the child is not responding, you send for help. And now you have opened the child's airway. Once you have opened the child's airway, you need to look for breathing. So the breathing is done by 3 things. You are looking at the chest movements, you are listening to the breath sounds, and you are feeling for the warmth of the breath. So look, listen, and feel. Okay, it will take only 10 seconds for this. So all these procedures, you take maximum 10 seconds, not more than that, right? So within 10 seconds, you will know whether the child is breathing or not. If the child is breathing, you allow the child to breathe. Look, listen, feel. If you don't see any chest movement, you don't hear any breath sounds, and you don't feel any breath in your cheeks, you have to give you 2 breaths, right? 2 breaths in order to open up the lungs. And how do you give the 2 breaths? In a small child, you need to cover both the nose and the mouth. In a bigger child, you give mouth-to-mouth breathing. But in a small child, you need to give mouth-to-mouth and nose breathing. Okay, it's not mouth-to-mouth. It's mouth-to-mouth and nose breathing. Okay, but in your setup, you don't need to give mouth-to-mouth breaths because everyone will have a bag and mask. That's the most commonly available instrument. So you can give bag and mask breathing if you have the device. Okay, so 2 breaths are more than enough. And how you know that your breaths are working is you will see the chest rising. If your chest is not rising, you need to go back to the airway maneuvers and redo the maneuvers and come back and do the breathing. So once you know that the child's chest is rising, that means the airway is clear, the lungs can be expanded, then C, check the pulse. Okay, again, you should not take more than 10 seconds. So how do you check the circulation? By checking the pulse. In a bigger child, you can look for the carotid pulse. In an infant, the neck is short, so the carotid pulse is difficult to feel, then you go for the brachial pulse. Okay, so these are the differences. In an infant, the brachial pulse. In a bigger child, you can check the carotid pulse. If you can't feel the pulse within the first 10 seconds, you have to immediately start CPR. Okay, so cardiopulmonary resuscitation. And how do we do that? In a smaller child, you can use two-finger method, right? So you can keep two fingers on the lower part of the sternum and push inwards. Or if you can encircle the child's chest, you can use both hands. This is much better because you know how much you are pressing, because your fingers will be guiding you. In this method, you don't know how deep you are going. So the danger is more for rib damage. Here, the rib damage is much less, right? Okay, and the compression rate should be 15 compression and 2 breaths. So if there are 2 people or even 1 person doing it, 15 compressions and 2 breaths. In a bigger child, you can either use, if the child is say less than 12 years old, you can use the traditional 2-hand method. Or if the child is somewhere between 6 and 12 years, you can use the single hand method. Okay, so in emergency situation, don't think much about that. Whatever you think is suitable, you can use. But in either way, make sure that the ball of the palm is pressing on the heart, not the fingers, right? The fingers should be lifted off the chest. So in both situations, the fingers are lifted off the chest. Otherwise, the pressure of your body will go through the fingers and go to areas which are unnecessary, right? By lifting the fingers, we are focusing the pressure mainly on the ball of the palm, which will directly go to the heart. So 15 to 2 for all children, and compression rate in all ages is 100 per minute. Okay, 100 per minute. In children, we expect a higher heart rate. That's why we have chosen the 100 heart rate. So 15 for 2 at a rate of 100 per minute. So now we'll go for summary. First, you look for dangers, then see whether the child is responsive. If not, send for help. Then there are 3 airway opening maneuvers: chin lift, jaw thrust, and head tilt. Look, listen, feel for breathing. If there's no breathing, you have to give 2 breaths, either mouth to mouth, or in a small child, mouth to mouth and nose. Or if you have ambu bag, you can do ambu bag ventilation. Then check pulse. In a small child, the brachial pulse. In a bigger child, the carotid pulse. If there is no pulse within the first 10 seconds, you start CPR, 15 compression for 2 breaths. And then you can attach, if you have a defibrillator, that's better, but a simple monitor is more than enough. And attach the monitor and see whether the help is coming. Until help comes, you can keep on doing CPR. CPR is safe, and you can continue for even hours if the help is getting late. Okay. Once the child get normal rhythm, normal heart rhythm and normal breathing, you have to keep the child on left lateral position. That is the position of recovery. So this is the DRS method of basic life support. Now we'll go to separate topics. So the first topic I will be choosing is the choking child. Okay. So this is very common in your scenario. Anything, any foreign body, the child can choke on. This can happen even at your home. So this is the latest guideline on how to manage a choking child. So first assess DRS, right? And then send for help and see whether the child is having an effective cough or ineffective cough. Okay. Effective cough means you think that the coughing is effective enough to push the foreign body out. So if you have an effective cough, then we don't need to do anything. We just encourage coughing and then support and assess continuously, right? Most of the time with effective coughing, the foreign body will automatically come out. If the child has an ineffective cough, that means the cough is not effective enough to push the foreign body out, then check whether the child is conscious or unconscious. If the child is unconscious, then you do the normal basic life support maneuvers. That means open the airway, give 2 breaths and CPR, and then check for foreign body. Before you check for foreign body, opening of airway, breathing, and circulation. Those things, 3 things are important, right? Without making sure that the airway, breathing, and circulation is attended to, do not look for the foreign body. If the child is conscious but not having effective cough, the child is conscious but the cough is not effective, you need to help the child. How you help the child is, you can give 5 back blows and 5 chest thrusts, okay? And you assess the child. If the foreign body does not come out, you can repeat the 5 back blows and 5 chest thrusts. So now we'll see how these are given. Before that, earlier in some guidelines, they recommend a finger sweep. Finger sweep means you put the finger and sweep around the mouth and try to get the foreign body out. But now it is not recommended, because by doing this, you might push the foreign body even more deeper. So finger sweep is not done. But you can inspect under direct vision. If the foreign body is very superficial, you can try and take it with a McGill forceps. That's a forceps which is used to remove foreign bodies. Back blows and chest thrust can be done. Heimlich maneuver is recommended for adults, but not for children. I will tell you why later. So this is how you give the back blows and chest thrust. When you are giving back blows, you need to keep the child in prone position with head low position. So the head is lower than the body, and you are giving back blows to the interscapular area. Right? So you give 5 back blows, the direction should be downwards and towards the head. So downwards and towards the head, you need to give the back blows. After that, if the foreign body doesn't come out, you can turn the child upside down, keep him on the supine position, and give 2 chest thrusts like in the same way you are giving CPR. Okay. Again, the direction should be down and towards the head. Okay, downwards and towards the head. You need to give 5 chest thrust. If the foreign body doesn't come out, you again turn the child prone and give 5 back blows. You can continue this until the foreign body come out. Usually with the second or third attempt, the foreign body should come out. If it doesn't come out, then you need ENT help, because we will need to do an emergency bronchoscopy and take the foreign body out. This is the Heimlich maneuver, which is done in adults. Why we do it in adults is, in children, the liver is further down. It's placed further down, and the liver is somewhere a little bit below the costal margin. So by trying to do the Heimlich maneuver, when you push upwards, Heimlich maneuver is you encircle the body with your hands, and around the solar plexus, you will push inward, trying to increase the intrathoracic pressure and push the foreign body out. But by trying it in a child, you might rupture the liver, right? So with the Heimlich maneuver, liver rupture has been reported. So therefore, we do not recommend Heimlich maneuver in children. Now we go to the second topic, status epilepticus. Okay. So children with epileptic disorders can develop status either due to a reaction to one of the drugs you give, especially sometimes pain can cause seizures, anxiety can cause seizures, because in dental practice, a lot of children get anxious during the procedures. They have fear, anxiety, that can precipitate a seizure, or one of the drugs you use can precipitate a seizure. So what do we do in status epilepticus? Status epilepticus is seizures going on for more than 30 minutes, or recurrent episode of seizures without child recovering consciousness in between the brief seizure episodes, right? The seizures may be brief, but in between the episodes, the child does not recover full consciousness. So once the status epilepticus is diagnosed, this is how you start your management. Now, status epilepticus it's a diagnostic which is done retrospectively, right? You won't wait for 30 minutes to start treatment. We will start treatment at 5 minutes. Once the treatment goes on, we will diagnose status epilepticus later. So imagine you have a child who is now fitting in front of you. Sometimes, most of the time, the seizure might resolve without any intervention within 5 minutes. All you need to do is turn the child into left lateral position. If you have oxygen, better to give high flow oxygen during the seizure and wait for 2 to 3 minutes. If the seizure does not settle, then you can start your first line management. Before you give the first line management, always check airway, breathing, and circulation. Okay, airway, breathing, and circulation. You can give high flow oxygen and attach monitoring. If the airway is obstructed or the breathing is not properly happening, do not try to control the seizure. Try to control the airway and breathing first, right? There is no point stopping the seizure if the child is not breathing. So give priority for airway, breathing, circulation, and then attend to the seizure. Any child with seizure, you have to check for hypoglycemia because that is the most common cause for seizures, the most common, easily correctable cause. So if you find hypoglycemic, the simple thing you can give is give 10% dextrose, 2 to 4 ml per kg. Okay, 10% dextrose, 2 to 4 ml per kg. So the first line agent at 5 minutes is benzodiazepines. Benzodiazepines, there are 3 benzodiazepines which we can use: diazepam, midazolam, and lorazepam. And you can use any route. If you have a cannula, intravenous. If you don't have a cannula, now the most current guideline recommends intramuscular benzodiazepines. It was not available, not recommended about 2 or 3 years back, but now it has been recommended that intramuscular midazolam can work very fast, almost like an intravenous midazolam. So you don't need to waste time looking for a cannula. You can straight away give intramuscular benzodiazepines. The other routes which are available is intranasal, buccal, or per rectal. Once you have given that, you can wait for another 10 minutes. Okay, not minimum 5 minutes or maximum 10 minutes. So at the end of the 10th or 15th minute, you can repeat another dose of midazolam or diazepam or lorazepam. Right? Remember, whatever the route you use, the maximum doses of benzodiazepines is 2. You can't use more than 2 benzodiazepines, right? The route may be different. You might give 1 IV and 1 rectal, or 1 rectal, 1 buccal. Whatever, the maximum doses in whatever route you can give is 2. Okay. So these are the doses for benzodiazepines. If you are giving IV, IV lorazepam 0.1 milligram, IV diazepam 0.15. If you are using IM, then it's 0.2. Intranasal, again 0.2. Buccal, slightly higher dose, 0.3. PR, you can go up to 0.5. So it's easy to remember: 0.1, 2, 3, 5. Right? Because rectal blood flow is very unpredictable, so you need to give a higher dose, 0.5. The buccal midazolam, buccal midazolam is another route. Again, the buccal blood flow is not predictable as intramuscular, so you need to give a slightly higher dose. When you are giving intranasal midazolam, remember, intranasal midazolam can be sprayed using a small syringe. Remember this 0.2 milligram per kg dose. That dose has to be divided and to give half to one nostril and the other half to the other nostril, right? Not to a single nostril. You have to use both nostrils. When you are giving PR diazepam, we need to use a NG tube and insert the NG tube through the rectum. Give the diazepam and remember to give a air flush, because otherwise, when you give a diazepam, sometimes half of the diazepam will remain in the NG tube without entering the rectum. by giving an air flush, you can push all the diazepam from the NG tube right into the rectum. That's a very important thing. So most of the time, we have found that the rectal diazepam has not worked because the diazepam is remaining in the rectal tube or the NG tube. Right? So after 15 minutes, if the first line agents are not working, that means you have given maximum of 2 benzodiazepines, then you can't use benzodiazepines. So you need to go for the second line agents, levetiracetam, phenytoin, or phenobarbital. Okay. And by this time, it is better to call the anesthetist or ICU because you might need ICU care. After 40 minutes, if the fit is still continuing, you can use again the second line agents or third line agent. Third line agent is intubation. Okay, so once you have gone through the second line drugs, you can use twice. If that is not working, you can go for the third line. That means sedation and intubation. Okay. When you are giving phenytoin, make sure that the child is connected to a cardiac monitor because phenytoin can cause cardiac arrhythmias. Phenobarbital, on the other hand, is a respiratory depressant. So make sure that you have your ambu bag ready. Right? So you give phenobarbital, sometimes the child can have respiratory arrest. No need to panic. We don't need to intubate. You just give ambu bag ventilation and we can restore the breathing back in about few minutes. Right? So important points regarding second line drugs, it should never be given as a rapid bolus. It should be given as a slow bolus over 20 minutes. And it should be diluted with the recommended diluents. You should never give second line anti-epileptic drugs as a pure drug. It has to be always diluted. For example, phenobarbital should be 1 to 10 times diluted. Okay. And if the seizure settles, do not stop the infusion halfway. For example, you have started a second line drug to be given over 20 minutes. At the end of 10 minutes, the seizure settles. Do not stop the infusion, complete the infusion. Right? Even if the seizure stops at 5 minutes, still you need to complete the full infusion. Otherwise, rebound seizures have occurred. And then it's very difficult to control them. Now we go to the third topic, anaphylaxis. Anaphylaxis is again another hot topic. Again, anaphylaxis can occur. Anaphylaxis theoretically can occur with any drug we use in our day-to-day practice. So what is the current guideline on managing anaphylaxis? So the first thing is very simple. You suspect anaphylaxis. You find there's a causative agent is identified, maybe, for example, a drug infusion, or another common agent is during a blood transfusion, right? So the first thing to do is discontinue the drug or discontinue the blood transfusion, which is causing anaphylaxis. If the agent is found, if you can't find the agent, that's a different story. But if you can find the agent, discontinue the drug. Then you go to the management. So intramuscular adrenaline is the first line of treatment. Even if you have a cannula, even if the child has a cannula, you should not use the cannula. You should go for IM adrenaline because with anaphylaxis, the veins are collapsed. And even if you give intravenous adrenaline, it will not reach the heart. Okay. And once you give IM adrenaline, check whether the child is hemodynamically stable. If the child is not hemodynamically stable, then you can repeat the intramuscular adrenaline dose. Okay. So first dose given, check for hemodynamic stability. If not achieved, repeat the second dose. Again, check the hemodynamic stability to check whether the blood pressure is recordable, check whether the pulse is now palpable, whether the pulse tachycardia is settling. If not, you can repeat one more adrenaline dose. Or you can even consider an adrenaline infusion. Okay. During the treatment of anaphylaxis, all the time you need to check whether the airway, breathing, and circulation is intact. So at any point while you are giving adrenaline, if you think the airway is not stable, you have to attend to the airway immediately. Someone else can take over the adrenaline administrating job, but your main aim is to protect the airways. So if the airway is compromised, you might need to intubate, or sometimes nebulizing with salbutamol and epinephrine is enough because that will open up the airways. And during the procedure, during treatment of anaphylaxis, always keep the child in lying down position throughout the acute management period. Sometimes the child might get better and try to get up, but that will be very dangerous because trying to get up during treatment of anaphylaxis, the blood pressure can crash and the child might end up with another episode. So always encourage the child to maintain a lying down position. Once the child recovers from the anaphylaxis, you need to do this. We need to monitor for a minimum of 4 to 11 hours. Okay. We need to monitor for a minimum of 4 to 11 hours. Because it has been noted that in some patients, a rebound anaphylaxis can come within 4 to 11 hours. So if the child get anaphylaxis at around 5 o'clock in the afternoon, you treat the anaphylaxis, child recovers. At around 6 o'clock, the child looks very, he looks okay. Never send him home. Admit and look after him until next day morning. Because if you send the child home, he might get a rebound episode in the middle of the night, and which can be very dangerous. Right? In anaphylaxis, you can use antihistamine. That means IV Piriton. IV Piriton is available. You can use it only if there is persistent pruritus. Otherwise, IV Piriton is not mandatory. You can also use intravenous steroids, but again, in current guidelines, it is not mandatory. Right? What is important is you give IM adrenaline. Now, what is the dose for IM adrenaline? IM adrenaline dose is 0.01 milligram, 0.01 milligram of, milliliter of 1 in 1,000. Okay, 1 in 1,000 adrenaline concentration. Now, in CPR, we use adrenaline as 1 in 10,000. Okay, that means we dilute it 10 times and use it as 0.1 ml per kg. But here we use 0.01 ml per kg of undiluted adrenaline. That is 1 in 1,000 adrenaline. Then we go to status asthmaticus. That is our fourth emergency. So status asthmaticus, a child can come with either severe asthma or life-threatening asthma. This is how we differentiate between severe asthma and life-threatening asthma. In severe asthma, the child cannot speak properly. He might have a big gap between each word. When he can't complete a sentence, he will have to breathe between words. In life-threatening asthma, the child will hardly speak. He will not speak at all because he can't speak. Even speaking a word is difficult due to the distress. The child will have severe tachypnea and severe tachycardia as severe asthma. But in life-threatening asthma, comparatively to the difficulty or to the state of the distress, the respiratory rate is slow and he has a relative bradycardia. That means the child is now giving up. He is in distress, but the heart is not fighting. The lungs are not fighting. The respiratory rate is coming down. Heart rate is coming down. This is a very serious situation. In severe asthma, the lung is full of bronchi, but in life-threatening asthma, the lung will be silent. You see the child in distress, you expect bronchi and you keep the state, you will hear nothing. Right? That's a very tight chest. In severe asthma, the child will be ill-looking and irritable. He's fighting. But in life-threatening asthma, the child is lethargic and even cyanosed. He has given up. So why we need to differentiate? In life-threatening asthma, you should have a very low threshold for ICU admission because you will need intensive care setup. Right? But in severe asthma, if you treat properly, you can avoid the ICU because in asthma, our main target is treat acutely, treat properly, and avoid intubation. Because in a child with asthma, if you intubate, it will be very difficult to wean him off the ventilator. Right? Intubation is easy, but taking him out of the ventilator is very difficult. So we always aim to catch the child in this stage before he goes into life-threatening asthma and bring him back to the normal functioning level. So how do we treat status asthmaticus? You can give back-to-back nebulization, usually 3 nebulizations without any gap. So you give one nebulization for about 10 to 15 minutes and then immediately start the second one and immediately start the third one. If the child is below 5 years, you give salbutamol 0.5 ml per nebulization. If the child is above 5 years, 1 ml of salbutamol, right, per nebulization. For the second nebulization, you can add ipratropium bromide. Normally, if you add salbutamol and ipratropium together, it has a synergistic effect. It will work better. So salbutamol improve the ipratropium effect. Ipratropium improve the salbutamol effect. Then you can start IV hydrocortisone 4 milligram per kg. Right? But remember, hydrocortisone, whether you give it IV or oral, it will take a minimum of 30 minutes to 1 hour for it to work. Okay. So although we give it as an acute drug, it will still take 30 minutes to 1 hour to start working. Once you have given back-to-back nebulization, you have to reassess the child. If the child is improving, you can tail off the nebulization. So you can go out to hourly nebulization, then 2 hourly, 4 hourly, 6 hourly, like that. With the frequent monitoring, you can tail off nebulization. If the child has not responded to back-to-back nebulization, the child remains same. Even after hydrocortisone, there is no improvement. You go to the second line drugs. We see second line. One is a single bolus of IV magnesium sulfate, 40 per kg, 40 milligram per kg. But you have to be very careful because mag sulfate can cause hypotension. So before you give mag sulfate, it is better to have a normal saline bolus ready. Right? Then IV salbutamol can be used. Unfortunately, it is not commonly available in our setup. But if you have, you can safely use IV salbutamol as an infusion. And IV salbutamol, the main danger is salbutamol can drive potassium into the cell. So in the blood, there will be very low potassium leading to hypokalemia, right? So you need to check or monitor serum electrolyte frequently. And if you detect hypokalemia, you might have to add additional potassium to the drip. Then IV aminophylline. That's the last drug which is available. Aminophylline you can use as an infusion, which we can continue for 12 to 24 hours. But again, aminophylline has a very narrow therapeutic range, and the most common side effect is cardiac arrhythmias. So if you are using aminophylline, you need to be ready to attend to a cardiac arrhythmia. And if the child has a cardiac arrhythmia, the most common arrhythmia will be a supraventricular tachycardia. Now, I haven't mentioned anything about supraventricular tachycardia, but I will tell briefly on management. If you have a supraventricular tachycardia, the management will be either pharmacological or non-pharmacological. Pharmacological is IV adenosine, but most of the time, non-pharmacological methods can reduce a supraventricular tachycardia. And the non-pharmacological method is you can place an ice pack on the face of the child. Okay. when you put a ice pack, a large ice pack on the face of a child, the child will get a vagal reflex. Vagal reflex, and the vagal reflex will try to settle down the heart. When the vagus nerve is stimulated, the heart rate will go down. That's a very common practice which is being used in our wards as well. So you collect a ice pack, cover it with a cloth, and cover the whole face with the ice pack. It should be done in a way that the child gets surprised by it, and when with that surprise, the vagal nerve is stimulated. Right. Now we come to the final topic of our lecture, cardiac arrhythmias. Okay, cardiac arrhythmias. So this is the universal algorithm for cardiac arrhythmias. Again, we have the approach, DRS approach, dangerous, responsive, send for help, and then open the airway manual. So you look for dangers, check whether the child is responding, send for help, and open up the airways. After opening the airways, you check for normal breathing. How do you check for normal breathing? You look, listen, and feel. If the child is not breathing, you give 2 breaths. After giving 2 breaths, check whether the chest is rising. If the chest is not rising, you have to recheck the airway opening manuals. Once you get the chest rising, that means the lung is patent, the airway is patent. You check the pulse, take no more than 10 seconds. If there is no pulse, you start CPR, 15 compression for 2 breaths. And now you will attach a defibrillator or a monitor, right? Monitor is more than enough. Once you attach the monitor, check the rhythm. Now there are 4 rhythms in pediatrics, which can happen in a cardiac arrest. There are 4 rhythms in a cardiac arrest. 2 are shockable rhythms. 2 are non-shockable rhythms. So we will first go to the non-shockable rhythm. That means if you have these 2 rhythms, there's no point giving a defibrillator shock. Okay. Now, thankfully, in pediatrics, in cardiac arrest, non-shockable rhythms are common. Okay. So most of the time, if a child is arrested in your ward, you will not need a defibrillator. Right? The non-shockable rhythm, there are 2 types, asystole or pulseless electrical activity. Right? So these are non-shockable rhythm, asystole and pulseless electrical activity. The shockable rhythms are ventricular fibrillation, pulseless VT. These are very rare in pediatric practice. Okay, these are very rare in pediatric practice. So asystole and pulseless electrical activity non-shockable, ventricular fibrillation and pulseless VT shockable. So this is a asystole. Asystole, if you do take in X-ray, very easy to diagnose. It will be a flat line. Okay, a very flat line, no waveforms. Now this is very nice rhythm. You can see all the waveforms. When you, at first glance, you might think, okay, the child is normal because the normal rhythm is there. But whenever the child is not responding, check for the pulse. Sometimes the child might, the heart, there may be a normal rhythm in the heart, but the heart is not actually beating. So when you check the pulse, the child will have no pulse. So you have a rhythm, but no pulse. That is called pulseless electrical activity of the heart. This is again a dangerous situation. If you do not do anything, the child might demise. So what is the so what is the pathway for non-shockable rhythm? So the non-shockable rhythm pathway, that is PEA asystole, all you need to do is give adrenaline 10 micrograms per kg. Adrenaline 10 mics per kg. That means 1 in 10,000 adrenaline, 1 in 10,000 adrenaline, 0.1 ml per kg. Okay, that's very easy to remember. 1 in 10,000, 0.1 ml per kg. You give adrenaline and immediately start CPR. Okay, so CPR for 2 minutes, check the rhythm. If the rhythm has not improved, again CPR. Again, after 2 minutes, check the rhythm. At the second CPR loop, you give adrenaline 10 mics. And then again, you go back to CPR. So it will be CPR, check, CPR, adrenaline, check, CPR, check, CPR, again, adrenaline, check, CPR, like that. So after every 2 minutes of CPR, you check the rhythm. If the rhythm has not come back to normal, you restart CPR. After 2 cycles of CPR, you give 1 dose of adrenaline. Right? Once a return of spontaneous circulation has occurred, you can stop CPR. While you are doing CPR, you need to check for 4 T's and 4 H's. Right? In cardiac arrest, there are 4 H's and 4 T's, which you need to check, because if they are present, if you don't correct them, the asystole will persist, right? You can't correct the asystole without correcting these 4 H's and 4 T's. So what are the 4 H's? Hypoxia. So the child should be always on oxygen. During cardiac arrest, you have to give oxygen. Hypovolemia. So if the child has low volume pulse, better to give a bolus or start an infusion. Otherwise, your CPR will not work. Check for hyper or hypokalemia. If you have those, you need to correct it. Hypokalemia, you can correct by giving potassium infusion. If it is hyperkalemia, you can do 3 things for hyperkalemia. Number 1, you can give calcium gluconate bolus. Calcium gluconate bolus. Number 2, you can nebulize with salbutamol. When you nebulize with salbutamol, potassium will be driven into the cells. Or you can give insulin dextrose infusion, because insulin also will push the potassium into the cells. So that is how you treat hyperkalemia. Insulin dextrose bolus, nebulizing with salbutamol, and number 3, calcium gluconate bolus. Finally, check for hypothermia. Right? If the child is hypothermic, unless you rewarm the child, your cardiac arrest management will not work. Then you have 4 T's. Okay, 4 T's. So the first T is tension pneumothorax. If there's a tension pneumothorax, you need to relieve the pneumothorax. Cardiac tamponade. If there's a tamponade, again, you need to relieve the cardiac tamponade. Toxic substances. If you think a child has ingested toxic substances while you are doing CPR, you need to detoxify. So you might have to give something like activated charcoal, or if you know the toxin, better to give the proper antidote while you are treating the cardiac arrest. And finally, check for thromboembolism. So these are the 4 H's and 4 T's which you need to look for and correct if the child is in cardiac arrest. So once the child has recovered, you need to do post-resuscitation care. That means reevaluate airway, breathing, circulation, disability, and exposure. Get a 12-lead ECG and confirm that the ECG is normal. If you have found any precipitating causes, treat it. Reevaluate oxygenation and ventilation and temperature control. Now, what is this rhythm? This is called a ventricular fibrillation. This is a very dangerous rhythm, but fortunately rare in children, common in adults. Right? This is a ventricular fibrillation. And that is a shockable rhythm, right? So if you have ventricular fibrillation or even a pulseless VT, ventricular tachycardia can be there without pulse. That is also a shockable rhythm. Here the difference is you give shocks, that is DC shocks or defibrillator shocks, and then give adrenaline, like in asystole, after each second shock. Then every third shock, you give amiodarone. Okay. So after a shock, you give these drugs and then CPR. So we'll see how it is done. So you have to give the first shock, CPR for 2 minutes, cardiopulmonary resuscitation for 2 minutes. Then you give the second shock. After the second shock, you give adrenaline. And then again CPR for 2 minutes. So after every shock, CPR. After the second shock, there's adrenaline and then CPR. Then you give the third shock, right? So all this time, after CPR for 2 minutes, you check the rhythm. If the rhythm is still ventricular fibrillation, you give shock. Otherwise, you can stop your resuscitation. So after the third shock, you give amiodarone. Then again CPR for 2 minutes. Then you give the fourth shock. After the fourth shock, again you have to give adrenaline, right? Because every second shock, so first shock, no adrenaline, second, adrenaline, third, no adrenaline, fourth, adrenaline. Like that, every second shock you give to adrenaline. Every third shock you give amiodarone. So the next amiodarone will be in the sixth shock. Okay, but hopefully, normally with 2 to 3 shocks, you should be able to recover the child. If the child is not recovering after the second shock, again check whether 4H and 4T are present, right? Like in asystole, ventricular fibrillation, the shocks will not work if your 4Hs and 4Ts are present. Hypothermia, hypoxia, hypokalemia, hypovolemia, tension pneumothorax, cardiac tamponade, toxins, thromboembolism. Once the child returns to spontaneous circulation, the post-resuscitation care is same. You evaluate ABCD, 12-lead ECG, treat any precipitating cause, re-evaluate for oxygenation, temperature control. Fine. So we now come to the end of the lecture. So today we have learned about basic life support, the DRS method, danger, response, send for help, then airway opening, breathing, circulation, and then after that, CPR. You have to continue CPR till help arrives. And then we learned about how to manage a child with choking, where the only recommended maneuvers are 5 back blows and 5 chest thrust. Finger sweep and Heimlich maneuver are not recommended. Then anaphylaxis, the most important thing is to stop the anaphylactic producing agent and give IM adrenaline. But you can give IV hydrocortisone and IV Peaditric if the need arises. But during management of anaphylaxis, airway breathing circulation, you have to take control. Then status epilepticus and status asthmaticus, again common. In epilepticus and asthmaticus, there is a protocol where you need to go from the first line of drug to the second line. But remember, before you give drugs, airway breathing and circulation should be corrected. And while you give the drugs, always remember there are side effects. And in status epilepticus, remember, you can't give more than 2 doses of benzodiazepines, whatever the route you use, right? So whatever the route you use, the maximum you can use is 2 doses of benzodiazepines. If you are using second line drugs, never stop the drug. That is a common mistake people do. Never stop the drug mid-transfusion. If the seizure stops, right, you need to complete the infusion. And then finally, in cardiac arrest, the most important thing to know is whether it's a shockable rhythm or non-shockable rhythm. Asystole and pulseless electrical activity are non-shockable, and they are very common in pediatric practice. Pulseless ventricular tachycardia and ventricular fibrillation are shockable rhythm. They are more common in the adult practice. Shockable or non-shockable, if your management is not working, That means you need to look for 4 H's and 4 T's. Okay, now you can ask any questions on any of the areas which you have learned today.
Thank you very much. It was a very interesting presentation, and you covered a wide range of medical emergencies that we have to face in the dental setup, or some of the emergencies are actually in day-to-day life, even when we are managing as dental practitioners. So there are a number of questions that have been sent by our dental surgeons who are joining with us. So now,
yeah, actually, I'm looking at one of the questions, a little bit about burn and animal bite.
yes.
Yeah, I'll attend to that first. Burns, I'm not an expert on burns because burns are covered mainly by the surgical team. But just a few facts on burn is that we need to look at the burn surface area, right? If the surface, now burn surface area is that whether the burn is more than 30%, 10 to 30%, or less than 10%. If the burn is less than 10%, you can manage with local burn management. That means you can apply local applications like Vaseline gauze, and even manage in the outpatient department. But if the burn is more than 30%, you need to you need to admit, because the child can die of dehydration and sepsis. So remember, if the burn surface area is more than 30%, it's critical, right? Even if the burn is less than 10%, if the burn involves some area like your hand, always refer to a burn center. Don't take a chance and treat with local applicants or local drugs, because contractures can develop. And once you get contractures, referring to the burn center after getting contractures may be too late. Okay. Regarding animal bites, dog bites, mainly dog bites, but monkey bites, dog bites, cats, whatever, you have to decide on about 4 or 5 important facts before we think about giving anti-rabies, either serum or vaccine. First, check whether the dog is vaccinated. If a dog is vaccinated more than twice, right, with anti-rabies vaccine, more than twice, and the last vaccine is within 1 year. Okay, so the dog is vaccinated more than twice, and the last vaccine is within 1 year, you can observe the dog and avoid the anti-rabies vaccine. You don't need to vaccinate yourself, right? But you need to observe the animal. If the animal dies without any reason or disappears, you can't find the animal, then better to get yourself vaccinated. You don't need to get the anti-rabies immunoglobulin, just the vaccination is enough. Okay. So vaccine state of the animal is important. So the animal should be vaccinated at least more than twice, and the last one should be within 1 year. The second one is where the bite site is. If the bite site is in the area like a finger, hand, nose, face, or genitalia, those are danger areas, because the poison can get absorbed very quickly. So you need to go for to the OPD and get, it's ideal to get at least a vaccine. If the dog is unvaccinated and you have a danger area bite, then better to get the vaccine and the immunoglobulin both. Then another important thing is if it's a provocative bite or non, say you make some mistake and make the dog angry and the dog bites back, that's a provocated bite. That is a low risk bite. If you are doing nothing and the animal suddenly came and bite you, that's a non-provocative bite. That is a little bit more serious, because the dog may be infected and he is now biting because the dog is showing symptoms of rabies. Another important thing is whether the wound is bleeding or not. Sometimes we get children who are having a little bit of scratch, no bleeding, no active bleeding, only a scratch. So if it's a provocated bite where the child was playing with the dog and accidentally dog scratches the child, there's no bleeding, you can observe the dog without getting the child vaccinated. But sometimes you might get a wound where there is very active bleeding. Now that's a high risk bite. And if you are not sure about the animal's vaccine status, or you can't observe the animal, say it's a wild animal who has bitten and gone, you can't observe the animal, and the wound is bleeding, then it is taken as a major bite. Then you need to get vaccinated. If you can, sometimes we start vaccination, but if you can find the animal and the animal is very healthy after 10 days, then you can stop the vaccination process after 10 days. You don't need to give the 30-day vaccine. Okay, so the important thing is the vaccine status, the bite site. Number 3, how deep is the wound, whether there's active bleeding or is it just a scratch. Number 4, whether it's a provocative bite or a non-provocative bite. And number 5, whether it's a domestic animal or a wild animal. Then there's some question on hypoglycemic attack. Okay, hypoglycemic attack, any age, you need to identify it. Now, for example, in children, if the sugar level is somewhere around 50 or 40, 60, that range, you can take it as hypoglycemia. But remember, in neonates, it is they have a high threshold. So even at levels of 30 or 40, you don't need to do anything. Normally, neonatal hypoglycemia is taken anything below 30. Okay. For a bigger child with hypoglycemia, all you need to do is you have to give 10% dextrose, 2 to 4 ml per kg. 10% dextrose, 10% dextrose, 2 to 4 ml per kg. Right. And there's a question on breath holding attack. Breath holding attack, actually, there's nothing much you can do. If a child develops a breath holding attack, there's an easy way of getting it down. You turn the child on his supine, on prone, and using your thumb, right, in between the two scapulae, you have to rub the spine a little bit in a hard way, right? When you rub the spine up and down in between the scapula, that will stimulate the respiratory center, right? Even in newborns, when they are born, if they are not breathing, that's what we do. We rub the spine in between the scapula, right? That's a very stimulative rub. And most of the children, when they are breath holding, if you rub hard enough, the child will gasp and start to breathe. Okay, that's a easy thing we even teach to our mothers, which they can do at home. And then once the child, now most important thing, if the child is using breath holding attack to control the adults, that's what they do. If a child is breath holding because you have not given something which is dangerous to the child, after the child recovers from the breath holding episode, do not give that object to him. Right? You have to show the child that the breath holding episode is useless. Right? If we want some toy from the shop, and if we do a breath holding episode after the recovery, if you give that toy to the baby, he will learn that breath holding episode is an advantageous thing, and he will keep doing it. Right? So the best thing is wait until the child recover from the breath holding episode. You can cuddle him, you can make him comfortable, but don't give the object which he was looking for. Right? Otherwise, it will become a learned behavior.
Thank you, sir. Unfortunately, we are unable to see your face today because of the difficulties you are undergoing. But even with that, thank you for participating and doing a wonderful lecture. So now, as dental surgeons, usually we try injecting the local anesthesia to our child patients. So in that case, how do we distinguish, once after injection, whether if they'll develop some sort of syncopic attack or some reaction due to the injection? How do we?
It's very common because we do a lot of vaccination, and a lot of children collapse soon after vaccination. So you need to identify whether it's anaphylaxis or syncopal attack.
Yes.
Very easy, right? Immediately check for pulse. Anaphylaxis is due to redistribution of fluid. So once a child falls down, he will be pale, cold, and there will be a tachycardia, right? And the pulse will be very thready and tachycardic. In syncope, it's a vagal stimulation. So the child will go into bradycardia and the pulse will be, normal volume, but bradycardic. That's the most easiest way of differentiating between a syncopal attack and an anaphylaxis. So because you never get bradycardia with an anaphylaxis, you might get it at the latter part of anaphylaxis. If you don't do anything for the child in anaphylaxis, after about 5 to 10 minutes, when the child is going to die, yes, the child might go into bradycardia, but not immediately. So immediately when the child falls down, you check the pulse. If the pulse is bradycardic but good volume, all you need to do is raise the limbs, lower limbs, and the child will recover or spray some water. But if you feel a tachycardia and 3D pulse, very difficult to feel pulse, that's the danger sign. You need to immediately treat as anaphylaxis. If you're not sure, best thing is to treat as anaphylaxis, right? No harm in giving 1 shot of adrenaline.
Right. Thank you, sir.
Yeah.
So I'm sure everyone has been able to ask. If they have any questions, they can please make use of this.
I think I have answered all the
Yes, sir.
chats, right?
Right. So thank you very much, sir. I'd like to thank you on behalf of the dentistry, the club, which is the academic branch of Government Dental Surgeons Association. For thank you very much for accepting our invitation and doing a wonderful lecture today. And I hope that everyone who joined today's lecture were able to gather a lot for their day-to-day practice. And also everyone is asking whether the recording will be available for them. Yes, we'll be making sure in the next within the next month that all the recordings will be shared to you so that you can enjoy and go through this lecture whenever time permits. So thank you very much.
Yeah, and I can share the PowerPoint with you at any time.
Thank you very much, sir. We can share with our members right away. Right.
Sure.
Thank you very much.
Okay, then.
And thank you, everyone.
Thank you very much. Thank you. Bye.